Hello, everyone, to Anesthesia Clinics, part of Edusurg. Today, we are going to talk about intravenous induction agents. This is the fifth talk, which we're going to talk about is ketamine today. So let's see. Ketamine is, again, a very commonly used drug. It has been used for a very, very long time. Now it's got into a lot of disrepute, is not a commonly used agent as a first choice for induction, but it has got many, many other positive uses and is used as a part of your balanced anesthesia technique. It is a structural analog of phencyclidine derivative, okay, very commonly used in veterinary anesthesia, and unfortunately can be used as a drug of abuse. Um, because of that, now it has been made a licensed drug. It is similar, it is sold similar to your any other opioid drug to avoid its abuse. Okay, so the licensing has become very strict and it needs triplicate prescription, etc. Okay, and the record maintained about how much is used and everything is kept very strictly now. So if you cannot just abuse it, and it is not available over the counter. It is a one-tenth as potent, yet retains many of its phencyclidine psychotomimetic effects. High lipid solubility, pH of 3.5 to 5.5. Mechanism of action, it inhibits the N-methyl N-aspartate, the NMDA channels, and neuronal hyperpolarization, activated cationic channels. Functionally dissociates the sensory impulses from the limbic cortex. So you really you feel something, but your brain doesn't perceive that. So that is why it's called dissociation, okay, which is involved with the awareness of sensation. So dissociative anesthesia, if you hear, it is only ketamine. This is the only drug which causes dissociative anesthesia. So patient is conscious. Okay, most of the drugs, when you give, the patient automatically closes eyes, but with ketamine the eyes remain open. Okay, it is a bit scary and weird. And a patient may swallow, patient may have muscle contracture, but unable to process or respond to sensory input, will not follow your commands, but patient appears to be awake but actually is unconscious. Additional actions on endogenous and analgesic pathways. It is an extremely strong and potent analgesic. Okay, that is one of the most positive uses of ketamine. Pharmacokinetics, absorption, it is given through various routes. It can be given orally, nasally, rectally, subcutaneously, epidurally. But epidurally, it is not FDA approved. Okay, so it is better to avoid. In clinical practice, it's given intravenously or intramuscularly. Peak plasma levels usually achieved within 10 to 15 minutes after intramuscular injection. So induction of general anesthesia, if you're giving, then you use most commonly 1 to 2 milligram per kilogram IV. Intramuscularly, if you're giving 4 to 6 milligram per kilogram. For maintenance, 0.5 to 1 mg per kg IV with balanced anesthesia, nitrous or and sevoflurane. 15 to 45 microgram per kilogram per minute IV with nitrous 50 to 70% with oxygen. Okay, and higher dose if you're using without nitrous. Sedation and analgesia, 0.2 to 0.8 mg per kg IV over 2 to 3 minutes. Okay, so pretty much it is half of your induction dose, and 2 to 4 milligram per kilogram of intramuscular. Preemptive or preventive analgesia, 0.15 to 0.25 milligram per kilogram IV. Distribution, again, highly lipid soluble, induced increases in cerebral blood flow and cardiac output, rapidly, rapid uptake by the brain, and subsequent redistribution. Half-life is only 10 to 15 minutes. Awakening is due to redistribution from brain to the peripheral compartments. In the liver, to several metabolites, norketamine retains anesthetic active, so it's an active metabolite. Repeated doses may cause tolerance. Extensive hepatic uptake with an extraction ratio of 0.9. That is why it's got a very short elimination half-life of 2 hours, excreted renally. Okay, so CNS effects, increases cerebral metabolic rate of oxygen, blood flow, and increased intracranial pressure, which can be reduced if you're giving it with another sedative, thiopental, diazepam, midazolam. Okay, if you're using it as a TIVA technique with propofol, and if you're using it with propofol, automatically you can reduce the dose of ketamine from an induction dose to maybe a maintenance or an analgesic dose. So then all these side effects can be reduced. Okay, high incidence of emergence reactions depends on the age, dose, gender, psychological susceptibility, concurrent drug use. Benzodiazepines attenuate incidence and severity. Hence, ketamine is not given on its own. And you also have to give an anti-sialogogue, like a glycopyrrolate. So you give glycopyrrolate, you give midazolam. After some time, once their action is sort of in place, then you give ketamine at a lower dose. So all your side effects can be drastically reduced, and you will get only the positive effects of ketamine. So cardiovascular effects, cardiovascular stimulant, okay, increases in blood pressure, heart rate, cardiac output, and PAP. Baroreceptor function attenuated via effect on NMDA receptors in nucleus solitarius, causes sympathoneural release of norepinephrine. Okay, so patients where we had like we used to say in sepsis or in emergency cases where a patient is hypovolemic, so because it will not cause fall in BP, it will cause tachycardia and will maybe sustain the BP blood pressure due to all these effects. But if patient is already has a depleted catecholamine stores and is already in like a collapse state, then the ketamine will not get the positive effects you want. It may cause further depression of the myocardium. So be careful, see your patient status, and only then use it. If your indication is solely to get the BP up, because if patient is already having depleted stores, you're going to just aggravate the situation. Respiratory effects, it has got minimal response in central drive. Okay, response to CO2 is preserved and transient decrease in minute ventilation. So this drug, if you use if it's used with propofol, your use of propofol goes down. So the apnea caused by propofol can be avoided if you use ketamine. So you use the good of both, right? Because ketamine does not cause apnea, it will take care of the pain, and it causes dissociative anesthesia, and propofol will allow you to use a lesser amount of ketamine. So all the psychotomimetic effects and the raised ICP and all that goes away because you're using a sort of induction dose. So again, the combination of ketamine and propofol is very good, similar to how we use midazolam and fentanyl. Okay, it is a very good combination, and you get good effects of both, and the patient outcome is also much better instead of using both as a sole agent. Bronchial smooth muscle relaxant, again very good for patients who have known lung disease, good in bronchial asthma, good in small children who are so prone for spasm because of the high vagal tone. Okay, increases oral secretions, can produce upper airway obstruction followed by laryngospasm if you have a lot of secretions with due to use of ketamine. Hence I said it is important to use an anti-sialogogue like a IV glycopyrrolate before you give ketamine. Uses an indication, induction of anesthesia in hypovolemic patients, bronchospastic and reactive airway disease, intramuscular induction in children with difficult IV access. So when we give IM also, we combine it with midazolam and glyco and then give intramuscular injection. Okay. Maintenance of general anesthesia, analgesia and sedation during burns dressing, debridement procedures, supplementation of regional anesthesia. Also, ketamine can be given as a nebulization, okay, before general anesthesia. It is also said to suppress the airway reflexes and will reduce your incidence of broncho and laryngospasm. Side effects, sympathetic system activation, increased heart rate, blood pressure, cardiac output, myocardial oxygen demand, stimulates oral secretions, so use of glycopyrrolate is good. Increased intracranial pressure and intraocular pressure, again at higher doses. If you use it on analgesic doses, it is not a problem. In fact, in the smaller doses, it is nowadays, they say it is neuroprotective, okay, in smaller doses, of course. Can cause nystagmus, diplopia, blepharospasm, okay, especially when the ketamine effect is wearing off, you will see the nystagmus, so it is very classical. It of course goes away as the effect of the drug goes away. Increased muscle tone, potentiation of neuromuscular blockers, and allergies to ketamine is like very rare. avoid in a known case of raised ICP, raised intraocular pressure, penetrating eye injuries. Okay. Psychiatric disorders, because many times the emergence is, if you use ketamine as a sole induction IV agent, IV induction agent, patients get up sometimes very violent, or they start talking irrelevant, they become they go a little out of control. So that is why, as I said, nobody uses ketamine as a sole induction agent anymore. So of course, patients who have pre-existing issues with like psychiatric issues or any other issues, which can cause aggravation of these signs, it is better to avoid ketamine. Okay. And avoid is at a sole anesthetic agent in any patient with known hypertension, ischemic heart disease, and cerebral vascular disease. Okay. Thank you very much.